So today we'll talk about hypercalcemia. Normal calcium level is 8.5 to 10.5 milligram per deciliter. So hypercalcemia is said to occur when it is more than 10.5 milligram per deciliter. Now before we go on to how to approach a case of hypercalcemia, we need to know about the clinical features of hypercalcemia. It's very easy to remember these clinical features. As the common saying goes, pain bone, renal stone, abdominal groan, and psychic moan. That means a patient of hypercalcemia have bone pains, renal stones, nephrolithiasis and nephrocalcinosis, which in turn results in polyuria and polydipsia. Abdominal groan. Abdominal complaints includes nausea, vomiting, anorexia, constipation. Abdominal pain can be because of peptic ulcer disease or pancreatitis. And psychic moan, it includes fatigue, depression, confusion, decreased concentration. Apart from that, there is QTC shortening of QT interval which predispose to arrhythmic state, and also proximal myopathy and muscle atrophy. Now let's talk about how to approach a case of hypercalcemia. So parathormone is the main player in calcium homeostasis. So first thing you have to assess in a case of hypercalcemia is parathormone level. If it is high, if parathormone level is high, so what will you think of? So that suggests that you are dealing with parathyroid related disorders. And it includes the most important and most common cause is hyperparathyroidism. And the conditions which result in hyperparathyroidism, most common in this is adenoma, which accounts for nearly 80% of cases. Carcinoma. An important point here I want to mention is that the patient which usually have parathyroid carcinoma leading to hyperparathyroid state have calcium in the range of 14 to 15 milligram per deciliter. Another conditions which lead to hyperparathyroidism is MEN syndrome, multiple endocrine neoplasia syndromes, primarily MEN 1 and MEN 2A. MEN 1, which is also known as Wermer syndrome, it consists of pituitary adenoma, parathyroid adenoma, and pancreatic neuroendocrine tumors. Patient can also have Zollinger-Ellison syndrome. MEN 2A, which is known as Sippel syndrome, it consists of parathyroid adenoma, medullary carcinoma of thyroid, and pheochromocytoma. Here only I want to mention another condition which leads to hyperparathyroid state, that is hyperparathyroidism and jaw tumor syndrome. In this, apart from hyperparathyroidism, there is presence of jaw tumors. Another parathyroid related disorder which leads to hypercalcemia is lithium therapy. Now, how does lithium therapy results in hyperparathyroidism? Lithium, it decreases the sensitivity of calcium sensing receptor. So as I have discussed yesterday, supposingly it is a parathyroid secreting cell. Here there is a calcium sensing receptor. It sends the serum calcium concentration and accordingly regulates the release of parathyroid hormone. So if there is down regulation of calcium sensing receptor, or there is decreased sensitivity of calcium sensing receptor due to any cause, so it sends the ambient calcium concentration as low even in the presence of hypercalcemic state, and therefore there is impaired abnormal PTH secretion. So even in the presence of hypercalcemic state, abnormal amounts of PTH is secreted, and which further exacerbates the hypercalcemia. Another important parathyroid related disorders are genetic conditions. The most important in this is familial hypocalciuric hypercalcemia. Now it is an autosomal dominant condition. In this, there is an inactivating mutation of the calcium sensing receptor. So again, because there is an inactivating mutation of calcium sensing receptor, so the serum blood calcium concentration is sensed low, and inappropriate release of PTH occurs even in the setting of hypercalcemia. So this results in hypercalcemia. Now, this calcium sensing receptor is also present in renal tubules, and again it sends the blood serum calcium concentration to be low, and there is inappropriate excessive reabsorption of calcium from renal tubules, resulting in decreased secretion in the urine and hypocalciuric state. Now, when do you suspect? If you come across a patient who is less than 10 years of age and is having increased calcium level, you should think of familial hypocalciuric hypercalcemia, particularly if there is a family history. Now, another genetic condition I want to discuss here, Jensen's syndrome. Now, strictly speaking, again it is autosomal dominant. Now, strictly speaking, it is not a hyperparathyroid state. Rather, in this condition, PTH is undetectable or low. So Jensen syndrome, the primary pathology in this is constitutionally active parathyroid receptor. So even in the setting of very low PTH levels, because there is constitutively active PTH receptor, so it results in hypercalcemic state. And there is short-limbed dwarfism associated with it. So I think so far I am clear that if a patient of hypercalcemia presents to you with the following symptoms, and you first thing you do is you get his IPTH levels done. If it is high, so you will think of primarily parathyroid related disorders, which are hyperparathyroidism, lithium therapy, and genetic conditions. Among these conditions, hyperparathyroidism constitutes a majority of cases. Now, adenoma is the primary cause in nearly 80% of cases. Another is carcinoma. In carcinoma, usually you come across calcium in the range of 14 to 15 milligram per deciliter and Men's syndromes. So it is usually associated with other endocrine abnormalities as well. Lithium therapy, if a patient is on chronic lithium therapy because of bipolar disorder or because of anxiety disorder, and you can come across hypercalcemia in that patient, so you should think of lithium therapy as the primary cause. And genetic conditions, particularly if there is a family history and if it is less than 10 years of age and you come across hypercalcemia, so you should think of familial hypocalciuric hypercalcemia. Now, how will you distinguish between the hyperparathyroidism and familial hypocalciuric hypercalcemia? So apart from age and family history, if you get the urinary calcium levels done, so it is low in case of familial hypocalciuric hypercalcemia and it is increased in case of hyperparathyroidism. Another condition, again family history is present and hypercalcemia is present, but PTH levels are very low or undetectable, and there is dwarfism, particularly short-limbed dwarfism, so you should think of Jensen's syndrome. So this is all what I have to say about the hypercalcemia. Now moving on to the another spectrum in which IPTH level is low. So if IPTH level is low, so what all you have to think of? First thing you should do is you should look for PTH related peptide. Because apart from hyperparathyroidism, PTH related peptide, both of these combined together account for 90% cases of hypercalcemia. So next thing, best thing you have to do is you calculate PTH related peptide, you assess PTH related peptide levels. And if it is high, so you should think of malignancy related causes. Malignancy related causes. Now strictly speaking, you should think of humoral hypercalcemia of malignancy. And particularly it is more common with squamous cell carcinoma of lung, of head and neck, of kidney and genitourinary tract. Squamous cell carcinoma of head and neck, lung, kidney and genitourinary tract. Now here only I want to mention that what could be the other malignancy related causes which can result in hypercalcemic state. If there is direct bone marrow invasion, like it is seen with hematological malignancies like lymphoma, leukemia, multiple myeloma. And another malignancy related cause is osteolytic metastasis. Now another important clue I want to leave here is When will you suspect humoral hypercalcemia of malignancy? Particularly if a patient is asymptomatic and he is having chronic hypercalcemia, say for more than 1 year, then it is unlikely. Then you should think of hyperparathyroidism, primary hyperparathyroidism as the cause. Because in this condition, usually the history is short, there is acute onset of hypercalcemia and it is usually symptomatic. Now, supposingly if PTH levels are low, if PTH related peptide levels are low, then what will you think of? Then you should go for vitamin D levels. Now, vitamin D is another important player in calcium homeostasis. So you need to assess if there is increased 25 hydroxy vitamin D levels. That means the patient is having vitamin D intoxication. Usually vitamin D intoxication, it responds to discontinuation of vitamin D, proper hydration, and if required, you can add glucocorticoids to this patient. If there is increased 125 dihydroxy vitamin D levels, which is the active metabolite, so there could be two causes. Either the patient is having granulomatous disorders like tuberculosis, like fungal infections, like sarcoidosis. Now, in granulomatous disorder, there is increased activity of 1-alpha hydroxylase enzyme. So there is increased conversion of 25 hydroxy vitamin D to 125 dihydroxy vitamin D. And mind you, this conversion into this conversion of 25 hydroxy vitamin D to 125 dihydroxy vitamin D is not under negative regulation, as is the case in kidney conversion. Now, another situation could be idiopathic hypercalcemia of infancy. Now, the classical cause in idiopathic hypercalcemia of infancy is Williams syndrome. Now, Williams syndrome, it consists of supravalvular aortic stenosis, mental retardation, and elfin phases. Another cause of idiopathic hypercalcemia of infancy is deficiency of 24 hydroxylase. 24 hydroxylase deficiency. This enzyme is responsible for the metabolism of 125 dihydroxy vitamin D to an inactive metabolite 24-25 dihydroxy vitamin D. So if there is a deficiency of 24 hydroxylase deficiency, so again it results in increased 125 dihydroxy vitamin D. Now supposingly there is normal values of or decreased values of 25 hydroxy vitamin D and 125 dihydroxy vitamin D, then you should look for renal failure as the cause. So if renal failure is present, so what could be the causes? Now, mind you, renal failure can result in hypocalcemic state as well as hypercalcemic state. Now, how it results in hypocalcemia? The most important cause is severe secondary hyperparathyroidism. Severe secondary hyperparathyroidism can result in hypercalcemia. Another cause is milk alkali syndrome, which is rare nowadays. Milk alkali syndrome, it occurs due to excessive ingestion of calcium and absorbable antacids like milk or calcium carbonate. So classically, there is a triad of hypercalcemia, alkalosis and renal failure. Another condition is aluminium toxicity. So aluminium toxicity is usually seen in patient who is on chronic dialysis because aluminium containing phosphate binders are used, but it is a rare phenomenon nowadays. Aluminium toxicity is usually manifest as acute dementia and unresponsive severe osteomalacia because there is deposition of aluminium into the bones and it hampers the deposition of hydroxyapatite crystals into the bone, so that results in hyper osteomalacia. Now, if you treat this condition with vitamin D analogs or calcium, so there is increase in hypercalcemia because of poor skeletal responsiveness. So severe secondary hyperparathyroidism, milk alkali syndrome, aluminium toxicity, this is the cause of renal failure. This is the cause of hypercalcemia in the setting of renal failure. Now, if renal failure is absent, then you should think of high bone turnover conditions. Now, high bone turnover, it occurs in hyperthyroidism, nearly 20% cases of hyperthyroidism. It occurs in immobilization, particularly in children and adolescents. Immobilization can result in hypercalcemia. Vitamin A intoxication, because vitamin A impairs bone resorption. So vitamin A, if taken in amounts access to 50,000 to 1 lakh international unit daily, so it can result in hypercalcemia because it impairs bone resorption. And thiazide therapy, chronic thiazide diuretic use. So this is all about hypercalcemia. So I have told you, first thing you have to do is you have to assess IPTH levels. Second thing is parathormone related peptide levels, because primary hyperparathyroidism and humoral hypercalcemia of malignancy, this accounts for nearly 90% of cases. How to distinguish between the two? If the patient is having chronic history, asymptomatic hypercalcemia, incidentally detected on lab evaluation, so you should think of primary hyperparathyroidism. But if a patient is having acute onset, symptomatic hypercalcemia, short history, then you should look for occult malignancy. And in PTH and this humoral hypercalcemia of malignancy, the IPTH levels are low. So this is the clinching point. Now, if PTH related peptide levels are also normal or low, then you should look for vitamin D levels, which is another important player in calcium homeostasis. Now, depending upon whether there is an increase in 25 hydroxyvitamin D or 125 hydroxyvitamin D, the causes are vitamin D intoxication, granulometer disorders and Williams syndrome. Now, if there is normal vitamin D levels, then you should look for renal failure. If there is renal failure, then probably the causes are severe secondary hyperparathyroidism, milk alkali syndrome and aluminium toxicity. And in the absence of renal failure, the last option is high bone turnover can result in hypercalcemia. So this is all about hypercalcemia. Thank you very much for your patience. I'm looking for your reviews and also looking for You can ask me for any topic you want me to discuss. Thank you very much.